everyone, welcome to ENDietS Talks. My name is ENDietS, and alongside with my colleague Ezgi Melody Calais, we are ENDietS Joint President and your hostess for today. So to celebrate Rare Disease Day, which happens on the 28th of February, we are going to talk a little bit about phenylketonuria. And to help us with this interesting topic, we have with us today Professor Júlio César Rocha. So Professor Júlio is a nutritionist at the reference center, Centro Hospitalar Lisboa Central. He's a researcher and professor at Nova Medical School in Lisbon, Portugal. He's the chair of the dietitians group of the Society for the Study of Inborn Errors of Metabolism, as well as the chair of the nutrition group of the Portuguese Society of Metabolic Disorders. He's the president of the Portuguese Society of Clinical Nutrition and Metabolism, member of the working group of the European Phenylketonuria Guidelines, and much more. So Professor Júlio, thank you very much for accepting our invitation. We are really glad. So maybe going right into the questions, let's start with an easy one. Can you please explain to us what is phenylketonuria and what is the prevalence of it in Europe and in Portugal?
First of all, hello everyone. So thank you very much for your very kind invitation to be with you this afternoon in order to celebrate an important day for rare diseases. But I would like to say that the diseases may be rare, but the patients not, because altogether they really represent a huge community. So my congratulations for your organization to put this important topic on the agenda. So, in fact, phenylketonuria is an inborn error of protein metabolism caused in the great majority of the patients by a defect on the phenylalanine hydroxylase enzyme, which is a liver enzyme that catabolizes phenylalanine, the essential amino acid, into tyrosine, a non-essential amino acid. Obviously, when there is a problem on this hydroxylation pathway, the patients manifest biochemical phenotype characterized mainly by increased phenylalanine levels in the blood and decreased tyrosine levels, giving rise to an increased ratio of phenylalanine tyrosine. This ratio, phenylalanine tyrosine, which is sometimes very high, disturbs the transport of phenylalanine and other large neutral amino acids across the blood-brain barrier and will affect the concentrations of several amino acids in the brain, affecting protein metabolism, myelin synthesis and turnover, other activities of other important enzymes of our intermediary metabolism, and not less important, they will affect, of course, the substrates for neurotransmitter synthesis and will affect neurotransmitter balances. So the main result when PKU is not treated results in a severe neurological impact with mental retardation in patients who are not early diagnosed in the neonatal period. In fact, during the last 6 decades, in the great majority of, or at least not great majority, but in an important number of European countries, newborn screening has been started, allowing patients to be diagnosed before clinical symptoms are detectable. And this has allowed to calculate the incidence of this disorder. And it is interesting that on average, at the European level, we can say for sure that it will roughly be around 1 to 10,000 newborns. So one patient diagnosed within 10,000 newborns, but there is striking differences in different countries. For instance, in Italy, we may have a very high frequency of PKU resulting around one affected child within 2,700 newborns. And in the same way in Ireland, roughly 1 in every 4,000. But very interestingly, in Finland, for instance, the incidence is lower than 1 to every 100,000 newborns. These results, probably in different genetic backgrounds, results in different consanguinity frequencies that obviously are explained by the fact that the genetic transmission of the disorder is autosomal recessive, which means obviously that both parents should be carriers of the mutation that will be transferred to their child. So we have a panorama that obviously in Portugal is very nice, because we have newborn screening implemented since 1979.
And as you say, even though it's considered a rare disease, the patients are not. So there's clearly a lot of interest in it. And as you know, the majority of our audience is nutrition and dietetic students. So we are sure that they are wondering if you can explain to us, what is the dietitian role in the management of phenylketonuria?
Thank you very much, Ines. That is really a very important and remarkable question. The critical role in treatment of PKU patients, that role is linked to the nutritionist and dietitian role. Because in the great majority of the patients, the nutritional treatment is the only strategy that we can be using. I think PKU as the first inborn error of metabolism that was successfully treated, as Dr. Bickel proposed in the 50s of the last century, should be viewed as a challenge for all of us. And why I'm saying that? Because immediately in the neonatal period, our role should be to limit the amount of phenylalanine that the newborn is getting, because we need to adjust the phenylalanine intake according to what we can expect about the disease severity, that at the first step can be estimated by the results of the newborn screening, the results of the phenylalanine in the blood. Obviously, we should not dismiss the possibility of other reasons that may contribute to the increase of phenylalanine-tyrosine ratio, but as a general rule, as much as the Phe increases in the neonatal period, the highest will be the severity of the PKU. So we need to restrict breast milk, we need to restrict the infant formula, which are obviously in the neonatal period the only phenylalanine sources for the newborn, and we need to prescribe phenylalanine-free amino acid mixture that will give all the rest of the nutrition that the babies will need because of the restriction we are imposing. So the great interest of this is as long as we start nutritional management in a newborn with PKU, it is a long journey we see in our front, a continuous balance between what we call natural protein intake, the protein that will give the essential amino acid phenylalanine, but that should be strict or should be restricted to the minimum necessary to allow a normal growth and development without being harmful to the brain, toxic to the brain. So this critical balance that sometimes it's not that easy to define is really the task of the nutritionist and dietitian to really establish the best ratio of these two sources of protein and nutrition to allow a normal growth and normal development without the side effects of the disease.
Thank you. This is really highlights the importance of dietary management and dietitians' role in PKU and their life. So the next question would be about what are the biggest challenge experienced by the patient with PKU in their social life? And in your opinion, what should we as a dietitian or dietetic professionals to help them and understand them better and cross this challenge, these barriers together with them?
Thank you very much for your question. You really hit the point because, on the logo of Nova Medical School, we have the 3 rings, as you can see on my back. One is the teaching, the middle is research, and the outer ring is community. So we need to be focused on community. And when we are taking care of a newborn with PKU, of course, we should be making our nutritional intervention based on the most recent scientific evidence. We should treat our patients as better as possible, but we need to understand that when we tell to a very young mother that she needs to restrict the breast milk because increased Phe levels will disturb brain development and will disturb normal development in her child, this can be a little bit challenging. So we need to carefully pass our message without making too much noise, without hurting too much this young mother. And this is one aspect I would like to emphasize, because if from 1 minute to the other you are very happy, you are living your dream, and if from 1 minute to the other you receive the news that there is a metabolite that is altered on the analysis of a very young newborn, and you need to change dramatically the physiological food pattern, you need to be very secure, but you need to be very careful in the way you explain this to a new family. So, interestingly, on the opposite, what we know from the evidence is that breast milk for patients with PKU, it's even more important than for other child, because not only because of long-chain polyunsaturated fatty acids enrichment that we have obviously in breast milk, but because we have some hypothesis that the increased Phe levels will disturb the activity of the enzymes responsible for the internal production of DHA and arachidonic acid. So the elongation and insaturation process that we have on our microsomal system may be affected by increased Phe levels. So from one side, we may need to tell to our young mothers that they need to restrict breast milk, and this may be disturbing for their self-confidence, for their self of guilty of this situation. Of course, it's not a guilty of anyone. It is the genetics that is playing their game, and we need to be one side very careful, and the other side to explain that as much as possible we need to promote breastfeeding, obviously making the adjustment with the special formula, the special phenylalanine-free amino acid formulation that these patients need to take. So altogether, we need to combine what should be the best nutrition for every newborn and how adjusted this nutrition should be made in a newborn with PKU. This is the main challenge, and only professionals knowing the best nutrition will know what would be the best adapted nutrition for a newborn with PKU.
Thank you for sharing different perspective. I think it's really valuable to know how they can affect by this disease, and also psychologically how it's affecting the mothers. And I want to ask one question related with this, that you mainly mention about newborn and early life, but how is the effect in the later life, maybe childhood, adolescent, when they are starting with the different environment, food environment, and they need to adjust their diet, of course, with this. So what are the challenge for both sides, for the patient side and dietitian side, to manage it in this surrounding of food and maybe limitations?
Thank you, Edgy, for your great question. Of course, I spoke about the neonatal period because it is the beginning of the journey. But in the preschooler age, at the first years at school, teenager years, of course, nutritional treatment of PKU is highly demanding in terms of the restrictions that these patients will feel in their social life, in their school career, in their professional career, in adulthood. We need to be very, very conscious that when we go to our job, when we have a child going to a school, and if the professor, the teacher, brings a cake to celebrate her birthday, all the students can celebrate tasting a small slice of the cake that the teacher brought. But this is not the case for a patient with PKU. And obviously, we are not here to contabilize nutrients. And Inez know me enough to recognize that we are not here contabilizing calories or specific nutrients. We are here to discuss what is the food pattern and how it affects simultaneously pathophysiological mechanisms of the disease and quality of life of our patients. And in fact, this is very demanding, especially in countries where adequate protein substitutes, so those phenylalanine-free amino acid formulas or special low-protein foods, which are specially manufactured produced in order to have very low Phe levels, allowing the patients to eat normally without being contabilizing every gram of a cookie, every gram of a bread, every gram of a milk replacer. So the nutritionist or dietitian should have all these details in mind, starting from the guidelines, being able to compose the daily menus, the food plan, and obviously having the chance to measure what will be the impact on the family's life, what will be the impact on child's day-to-day life at school, at extra school activities, wherever. Because if we don't care about all these details, we will not be successful. In a way, we will not be able to keep these patients on target, keep these patients with good metabolic control, preventing the neurological sequelae.
Thank you for the detailed answer. I think it's really important to understand the complexity of the dietary management and consider all the situation, environment, and everything for the patients. That brings us one more question that you mentioned about life quality and making their life better for them. So what would be your advice for students or for young dietetic professionals where we can start learning, and if we want to work together with the patients with PKU, or if we want to help them understand them, where is the starting point and how we can improve ourselves to helping them better.
Thank you very much for your question. In my opinion, the best way you have to help families and patients is to study more. The more you study, the higher level of knowledge, scientific level of knowledge you have, the better you can explain in simple words the disease and its treatment to the patients. That's my vision. So to young colleagues, they need to be very strong in a way they can construct solid knowledge on the disease and its treatment, and to explain to our patients. I will give you a simple example. When we restrict protein-rich foods that are obviously simultaneously rich in phenylalanine, not being able to include in the day-to-day food menu to our patients, we need to replace those food protein sources to phenylalanine-free amino acid mixtures. But the kinetic absorption of free amino acids is non-comparable with intact protein. This will affect metabolism. This probably will give rise to higher levels of insulin in a postprandial phase, and this will affect the ratio between satiety and hunger that our patients sometimes have difficulty to manage. In that way, it is not strange to see our patients saying, I just got lunch and 1 hour and a half, I'm hungry again. What's happening? We need to explain to our patients, to our families, that a synthetic diet that has been using for decades, showing extremely good results. It was really one of the best examples. I can demonstrate that if we don't have a patient under control, we will have an adult with mental retardation that will need to be institutionalized, and it will be a lost person for the community, for the society. But on the other hand, if we have a PKU, a classical PKU, a severe form of the disease, always on track, we may have a patient that can go to a public university. And we have that example in Portugal. The president of the Portuguese Association of PKU patients, she is a psychologist. She has been diagnosed earlier. She has been following the treatment for life, and she is one of the successful examples. So we need to explain this to our families in order they can accept better our changes to their life, our changes to their food menus. So this, I think, touches the point of health literacy, which is so actual, which is so needed in order that patients and families can understand the physiopathological mechanisms of the disease, and then they can understand that when we are making strict recommendations, we are not punishing anyone. We are just giving the right advice for them to follow because we are concerned with their prognosis.
Thank you for highlighting the unique condition of PKU and differentiating them than other diseases and other things. So I understand that it's very important to have a public awareness concerning this issue. And thank you so much for your time. That was all from our side. And we are so happy and honored to be here with you, having an interview on this PKU issue in the Rare Disease Day. Thank you so much.
Thank you. It was my pleasure, and congratulations for the work you have been doing. Thank you very much.